Thank you very much for this opportunity to discuss some of the results of our research in colon and rectal cancer. I will discuss the final step results of prophylactic versus reactive skin toxicity treatment for patients receiving panitumumab and having panitumumab-related skin toxicity. These are for patients with metastatic colon and rectal cancer. First of all, colon and rectal cancer is a big problem in our world. It is the third most common cancer worldwide, with approximately 1 million new cases of colon and rectal cancer diagnosed annually. For treatment, there are multiple therapies, and the epidermal growth factor receptor inhibitors being a major part of therapy. Panitumumab is one of two anti-EGFR therapies that are available. It is a human IgG2 monoclonal antibody, and it is directed against the epidermal growth factor receptor. However, many patients benefit from this therapy, but skin toxicities represent the most common treatment-related toxicity and treatment-related side effect of therapy. There have been no specific guidelines or therapies available for managing the skin toxicity. The skin toxicities can result in other complications for patients, such as infections and sepsis, and in some cases has resulted in death. The skin toxicities can also delay therapy, cause total cessation of therapy, and for patients this is really important that they receive their treatment. Not only that, the skin toxicity can affect appearance and quality of life. This is the first prospective study that has examined the differences in a skin toxicity regimen that will manage the skin toxicities and a reactive skin treatment that waits for the patient to develop the skin toxicity and then begin treatment. The treatment regimen consists of topically applied sunscreens, moisturisers, and topical corticosteroids with oral antibiotics, and this therapy is initiated prior to initiation of the chemotherapy. The results of our study showed that the primary endpoint, which was the incidence of grade 2 or higher skin toxicities, was reduced substantially by this prophylactic or preemptive skin toxicity. It resulted in less than 50% of the toxicities of the reactive skin treatment. For grade 2 or higher toxicities, this was reduced substantially. And note that for grade 3 or higher, the most serious toxicities, that the prophylactic skin treatment resulted in less than 1/3 the serious toxicities as waiting or the reactive skin treatment. Not only that, the preemptive or prophylactic therapy reduced the number of dose delays, with only 1% of patients in the prophylactic skin treatment arm experiencing a dose delay, while 6% of patients in the reactive skin treatment arm experienced dose delays. Dermatologic toxicities were evaluated. The orange represents the reactive or wakeful treatment arm. The prophylactic skin treatment arm is represented by yellow. And note that prophylactic therapy resulted in a decrease in dermatitis acneiform, decrease in pruritus, a decrease in the pustular rash, and no paronychia experienced by patients in the prophylactic treatment arm. Non-dermatologic toxicities were also evaluated carefully, and again, the yellow represents prophylactic, the orange reactive skin treatment, and note that the prophylactic skin treatment resulted in less nausea, vomiting, less fatigue, less diarrhea, less neutropenia, less hypomagnesemia, and less dehydration for patients. The conclusions from our study were as follows: that the incidence of grade 2 or higher skin toxicities during this 6-week evaluation skin treatment period was reduced by more than 50% in the prophylactic treatment group compared with the reactive treatment group. Numerical differences in favor of wild-type KRAS, which was evaluated, was also observed for all efficacy endpoints and anti-tumor effectiveness. The prophylactic and reactive skin treatment regimens had no negative effect on efficacy or anti-tumor endpoint, regardless of the KRAS status, tumor status. And patients in the prophylactic treatment group also reported an improved and enhanced quality of life. I thank you very much for your attention.
Thanks, Edith. This is a very simple and elegant study. Like we've learned from the management of many of the common side effects of our chemotherapies, it's more effective to prevent them than try to treat them when they occur. At that point, our interventions may be less effective, and our patients already in distress. The panitumumab-associated skin rash can occur in over 90% of our patients. I'm a GI oncologist, and I watch every day how my patients either refuse therapy, stop therapy, or receive a lower dose of the drug because of this disfiguring rash. I think this can represent a new standard of care for treatment of GI malignancy patients who are receiving these drugs. We now know that preventative treatment may enable them to better tolerate their therapy the same way we routinely use anti-nausea medications when we give patients cytotoxic chemotherapies.